everybody. My name is Aroma Dulku, and today we're going to be talking about does premedicating with acetaminophen and diphenhydramine prevent transfusion reactions. So a little bit of the outline for today, we'll talk about the history, the different types of transfusion reactions, what we would premedicate with, and different literature reviews, our in-house protocol, and then decide if we're going to bust or not bust this myth. So a little bit of the history behind this. In 1665 was actually when the first transfusion was ever done, and that was in dogs. The first human transfusion wasn't done until 1818, and it was in a woman who had postpartum hemorrhage. Her husband actually ended up giving her 4 ounces of blood. They took it out of his vein and then injected it into her. They repeated this about 10 times over a period of 4 hours, as seen in the picture on the left. In the 1900s was when we had the discovery of the different human blood groups, A, AB, AB, and O. In 1940 was when the Rh incompatibility was recognized as a cause behind most of the transfusion reactions at this time. In 1958, the American Association of Blood Banks actually ended up publishing a standard for blood transfusion services that recommended pre-medicating with diphenhydramine and acetaminophen. In 1960 to 1990, they started testing for bloodborne diseases like Hep B, HIV, and Hep C. And then in 2010, the CDC and the American Association of Blood Bank actually launched a hemovigilance module of National Healthcare Safety Network. And what this program did was all the hospitals across the United States were to report any sort of adverse events associated with blood products to help improve patient safety and identify effective interventions that we could do to decrease rates of reaction as well as infection. So what is blood made up of? Blood makes up about 7% of the human body, and it's made up of 2 components, plasma, which accounts for 55%, and then formed elements that make up 45%. The plasma is made up of water, proteins, electrolytes, and the formed elements is made up of the white cells, platelets, and red blood cells. The different type of blood products that we can give patients here in-house include whole blood, PRBC, FFP, platelets, albumin, cryo, and different clotting factors. As residents, we always get paged overnight or during the day. Some of the things that we commonly see are patient is admitted for septic shock with an initial temperature of 102.1, received a unit of PRBC, and now they're having a transfusion reaction of 103 with a temp of 103.1. Patient developed 2 hives after receiving a unit of platelets. Or can you place PRN orders for Tylenol and Benadryl as pre-medication prior to blood transfusion? So what exactly is a transfusion reaction? There's different types of transfusion reactions, and they're divided up into hemolytic and non-hemolytic. So we're going to be focusing on non-hemolytic transfusion reactions, which is febrile transfusion reactions and allergic reactions. So febrile transfusion reaction is usually when you have an increase in temperature by 1 degree associated with chills or myalgias, and it's supportive care. What you want to do is give these patients acetaminophen, and it is actually the most common type of reaction that you'll see. Allergic reactions, usually patients will present with urticaria, pruritus, hives. Anaphylaxis is extremely rare, and for these patients, again, it's just symptomatic control. So you give them antihistamines, and you don't ever stop the transfusion really for either one of these. For the allergic reaction, you're not really actually allergic to the blood, but it's secondary to antibodies, and we'll go into that in a little bit. Just to briefly touch base on the others, hemolytic transfusion reaction presents very similar to febrile in the sense that you'll have the fever and chills, but it's associated also with sometimes pain at the site of the reaction, nausea, vomiting, shock, and dark urine. And for these patients, you definitely want to stop the transfusion, give them a lot of fluids, and it's usually seen due to ABO incompatibility, which now is very rare given the fact that we type and cross patients before giving them any form of blood products. And then trolley presents very similar to ARDS. It's a transfusion-related acute lung injury. Patients will have like bilateral chest infiltrates, hypoxemia, and dyspnea. What you want to do for these patients, again, is stop the transfusion, make sure that you provide supportive care, and have good airway control. It's actually the one that's associated with the highest number of deaths compared to any one of these reactions, but it has a better prognosis than ARDS. And then TACO, which is transfusion-associated circulatory overload, is usually when patients present with dyspnea, edema, and what you want to do is slower the rate at which you're giving the blood, so over a period of 3 to 4 hours, and you can give the blood with diuretics, essentially. This is commonly seen in the elderly, patients with chronic anemia, and CHF. This was an interesting graph that I found in the New England Journal of Medicine that was published in 2017, and what it's showing is the adverse effects of blood transfusions in the black boxes, and it's showing these events per unit of red cells. And then in the blue, you see unrelated risks, so the risk of an airplane death per flight, the risk of lightning striking per year, or the risk of a motor vehicle accident for every 10,000 people. Ultimately, what this is saying is the chances of even having a reaction is extremely rare. And the most common reaction that you would see, if any, would tend to be like febrile and allergic reaction. Interestingly, TACO has been increasingly been reported up to like 1 to 5% of transfusion reactions. And it's thought to be secondary to more patients having CHF, CAD, or acute renal failure. So what is febrile non-hemolytic reactions? They account for 0.1 to 1% of blood transfusion reactions. They can occur in every 1 to 400 patients. There's a higher incidence in platelets versus PRBC. It's defined as a rise in temperature greater than 1 degree Celsius with or without chills, rigors, or mild dyspnea. It can occur anywhere from 30 minutes to 5 hours of transfusion. As far as pathophysiology, it's mediated by 2 mechanisms, either cytokine or antibody. The antibody-mediated portion of it's more common in RBC, so what happens is there are recipient antibodies against donor class 1 HLA antigens or platelets, and it activates the B cells to release cytokines like IL-1, IL-6, and TNF-alpha. The cytokine-mediated tends to be more common in platelets because platelets are stored at room temperature, so it gives them a way to kind of accumulate more leukocytes. And these leukocytes release the same exact cytokines you would see in like the antibody-mediated, which would be like IL-1, 6, 8, and TNF-alpha. What happens is that these cytokines end up going into the bloodstream and making their way to the endothelial cells in the hypothalamus, and it causes the release of prostaglandin E2, which then goes on and increases cyclic AMP, causing the rise in the thermostatic set point, increasing our overall body temperature. And what is allergic reactions? They're reported in about 1 to 3% of blood transfusion reactions and can occur anywhere between 1 to 100 to 1 to 500 patients. Isolated pruritus or localized disseminated urticaria, and actually 1 out of every 10 can cause pulmonary bronchoconstriction. Allergic reactions can occur anywhere during, at the end, or even after the transfusion, which really sets it apart from like something like anaphylaxis, which would be more immediate. The pathophysiology is that the recipient has IgE antibodies that react with the donor plasma, and this causes the mast cell or basophils to release histamine, which is essentially a type 1 hypersensitivity reaction. So for febrile and for allergic reactions, when did premedication come into play? Back in the 1800s, when we first started giving blood transfusions, 25% of those actually ended up having some sort of reaction. At that time, there wasn't really a standard for manufacturing restoring blood products. So based on observational studies in the 1950s, is when premedication was propelled into practice with acetaminophen, also known as paracetamol, and Benadryl diphenhydramine. by 2000 to 2005, premedication was actually used in almost 50 to 80% of transfusions. There's been very few studies that have evaluated the benefit of premedication, and you can see kind of on the bottom here, when we order any blood products in-house, it always gives us the option on the bottom if we want to give anything before giving the blood product. Acetaminophen acts as an antipyretic, so it blocks COX-3, which essentially inhibits the release of prostaglandin E2, so you don't have that change in the thermostatic set point that we talked about a little bit earlier. The thought behind this was that we would prevent febrile non-hemolytic transfusion reactions from occurring by making sure that that temperature wasn't adjusted for. The dosing for this is usually about 650 milligrams in adults and 10 milligrams per kilogram in children. The adverse risk for this is hepatotoxicity, so you always want to be cautious when you're giving this to patients with a history of cirrhosis. The toxic dose, though, is usually 15 times greater or close to 10 grams. For acute hepatotoxicity, it could be as low as 7.5 grams, or for chronic hepatotoxicity, even a lower dose down to 4 grams. So something to always keep in mind. Diphenhydramine works as an antihistamine, so it blocks the histamine effector cells, H1 receptors, in the GI, blood vessels, and respiratory tract. And the thought behind it was that it would prevent allergic reactions from occurring, like itching and urticaria. The adverse effects that you kind of want to be cautious for could be like drowsiness, cognitive impairment, decreased alertness, tachycardia, hypotension, vertigo. I just had somebody tell me yesterday that there was a patient on the resident service that got diphenhydramine before getting blood products, but then was too drowsy to go home afterwards, so they had to keep them in for an extra day. So it is commonly seen. The first study that was ever published on this was in 2002 by Wang, and it was in the American Journal of Hematology. They did a prospective randomized double-blind placebo-controlled trial where they had 65 patients with leukemia or stem cell transplant. 35 of these patients received 52 transfusions, and they were pre-medicated with acetaminophen 650 and diphenhydramine 25, so they had received both. And then 30 patients that were given placebo with dextrose and normal saline. What they ended up doing was evaluating non-hemolytic transfusion reactions, which they defined as a new temperature greater than 38 degrees Celsius or greater than 1 degree Celsius above baseline, subjective chills with or without rigors, urticaria, or rash. And what they noted was that the rate of non-hemolytic transfusion reactions was 15.4% in the pre-medicated group and 15.2% in the placebo group, with a p-value of 0.94, demonstrating really like no significance as far as reduction in reactions with pre-medication. This was followed by another study in the Archives of Pathology and Laboratory Medicine in 2004. This was a retrospective review study of febrile non-hemolytic transfusion reactions between 1998 to 2002, and it was also a cost analysis that was done in a hospital in the East Coast. What they did was they looked at nearly 119,000 adult blood product transfusions, and they noted that 80% of these patients actually received acetaminophen before they received any form of transfusion. Out of those 119,000, they found 109 cases of febrile non-hemolytic transfusion reactions. So the overall incident rate was 0.09, which was the lowest rate ever published. They also found that, as far as costs, when a patient is having a reaction, the workup for stopping the transfusion and kind of sending blood work to see if there's a reaction occurring was close to $8,600, and that included the laboratory workup, returning the blood products, and physician time. Whereas giving acetaminophen, they said, was only $1.54. What the study concluded was that acetaminophen can offer a cost-effective solution to minimize febrile non-hemolytic transfusion reactions. It prevents exposure to multiple donor units, decreases product wastage, and there's no evidence of dangerous transfusion reactions or masking acute hemolysis, septic shock, or trolley. This study, though, did receive a lot of criticism because if you think about it, if you're taking 80% of 119,000 blood transfusions, that's close to like 95,000 patients who received acetaminophen. And you times 95 by $1.54, your total is technically going to be $150,000. So technically, you're kind of spending a little bit more money giving acetaminophen than you are doing the workup for a transfusion reaction, which they failed to kind of talk about in their conclusion. And as far as kind of them saying that there was no significant masking of acute hemolysis or septic shock or trolley, well, if 80% of those patients are getting acetaminophen, you can't necessarily say that they were masked or not, because it may just not have been worked up. So this study got a lot of criticism in that regard. They also showed that they had a decrease in rate as far as febrile non-hemolytic transfusion reactions over that 5-year period from 1998 to 2002. But interestingly, between 2000 to 2001 was when the hospital ended up kind of transitioning to the universal practice of using pre-storage leukoreduced blood products. So that in itself could account for that decrease that we see from 2000 to 2001, because if you're using pre-storage leukoreduced products, you're really decreasing the amount of cytokines that are even present in the blood products you're giving your patients, therefore decreasing the risk of having a reaction. This was followed by another study in the British Journal of Hematology in 2005. It was also a retrospective review that looked at blood transfusions given to children at the St. Jude's Children's Hospital in 2000. There were 385 hematology and oncology pediatric patients that received platelets. So about 2,500 of these patients had no pre-medication, 1,000 had acetaminophen, 1,200 had diphenhydramine, and 3,000 had both acetaminophen and diphenhydramine. The results showed that 59 patients had an allergic reaction and 22 had a febrile reaction. When they looked at those who did end up having a febrile reaction, they compared acetaminophen versus them not receiving any medication, and it was 0.95% versus 0.56% risk, and then allergic reaction with diphenhydramine versus not giving any pre-medication was 0.90 versus 0.56. So really showed that there was no significant decrease in either febrile reactions or allergic reactions with pre-medication. And in 2008, there was a prospective randomized study that was done, double-blind, placebo-controlled, and this was done over a period of 3.5 years, and there were included about 315 patients with leukemia or bone marrow. They received either acetaminophen and diphenhydramine, or they received a placebo, and what they noted was that transfusion reactions occurred in 29 of those patients that were pre-medicated, and 33 of those that received a placebo with a p-value of 0.43. Allergic reactions accounted for 21 versus 15, and febrile 7 versus 14, and they too also concluded that there wasn't a significant reduction in the overall risk of transfusion reactions with pre-medication. There was a Cochrane review done in 2010 with two of the studies that we talked about, Wing 2002 and Kennedy 2008. They added on another study, which was the Wing 1992, and in that study they used small doses of hydrocortisone, 50 milligrams, and diphenhydramine as pre-medication for transfusions. So this review kind of took in 462 hem-onc patients and evaluated the primary outcome, which was did they or did they not have a febrile or allergic reaction. And you can see at the top that febrile reactions, the relative risk was 0.52, and the relative risk for an allergic reaction was 1.45. So it concluded that there was statistically non-significant risk. It was a statistically non-significant risk ratio for both febrile and allergic transfusion reactions. And what they said at the end was that there really wasn't any evidence for pre-transfusion medication preventing non-hemolytic transfusion reactions, and this applies regardless of if they had a reaction in the past. They concluded based on these 3 trials that prescribing pre-transfusion medication really wasn't justified unless there was new evidence from a larger, high-quality study. And then our protocol in-house I have up here. So in our hospital, if a patient has an increase in body temperature by a degree Celsius or 2 degrees Fahrenheit over baseline, chills, respiratory distress, hypotension. The protocol is to stop the transfusion reaction or stop the transfusion immediately. And you can't really continue it until you have approval from a pathologist and an ordering physician. The only exception would be like urticarial reactions, so allergic reactions. I did speak with Dr. Comer, who is our in-house pathologist, about it. And so I think, this is an area that we're working on kind of making changes to in the near future. Especially with the data that we've now seen that we shouldn't even be stopping transfusion reactions if we're thinking it's allergic or just febrile. You would only want to actually stop them if it's a hemolytic reaction, if you're thinking that it might be trolley or taco. And then a little bit of the summary. So routine premedication doesn't prevent febrile or allergic reactions. There's not enough evidence that really suggests that it's effective, given the fact that there's such a low incident risk of febrile or allergic reactions. It's not really good practice or prophylaxis. There may be, additional studies that will help, like patients outside of HEMONC, and there's no data that really suggests that having a history of a reaction will help the patient, premedicating the patient the next time around is really going to make a significant difference. And these are my references.
Okay. Anybody have any comments or questions?
In your research, did you find that people who did have a reaction, who got Tylenol or Benadryl afterwards, did they have like a more rapid resolution of symptoms or anything like that?
No, none of the research actually showed that or talked about it. But there were only a total of 6 literature reviews on the topic in itself, but none of them talked about resolution.
We will be voting on this. Is it a myth? Premedication or premedicating with diphenhydramine and acetaminophen prevents non-hemolytic transfusion reactions, something which seems like it's mainly the hem-onc people that do this. Do you guys ever? I never order this, I don't think. It seems like it's always the hem-onc people, maybe because they're giving a lot of transfusions to the onc patients that are getting chemo or whatever. I don't know.
I do it all the time for
Do you?
amphotericin.
For amphotericin.
It's the same thing. That's what I was taught. So
No
it's the same
data.
thing. You're doing
Yeah.
it forever.
Okay. All right. So I guess we'll vote. Is it a myth? How many people think that this statement actually is true and the data supports that we should be doing this? Nobody? How many think it's plausible? And how many think it's busted? Oh, everybody. Wow, it's unanimous.